do not have any relevant disclosures. So as an introduction, periprosthetic fractures around total knees remain a challenging problem, and these account for up to 10% of total knee component revisions. Most fractures around the femur are supracondylar fractures or have condylar involvement. The treatment options, which we're going to go over, are non-operative, which is very, very rare and uncommon and really only reserved for extremely medically frail and infirmed patients. Intramedullary nailing, plate fixation, revision arthroplasty, which is also rare, but some unique situations in which that would be an option, and distal femoral replacements. I would say, as a pertinent disclosure, I'm mostly an arthroplasty surgeon, so we'll be talking mostly about arthroplasty, but we'll also go over some cases of fixation. Some considerations, there are not really great classifications of, as in the hip, where the Vancouver classification can guide treatment and outcomes. There's not great classifications around the knee to help us, drive our decision making. So really, things that I consider and think are important are considering the patient age and comorbidities. How much are they going to be able to tolerate non-weight bearing, and what are the other comorbid conditions? Really looking at the x-rays and often CT scans prior to see what remaining supracondylar bone stock that you have if you're considering fixation. Obviously, the stability of the implants and whether they're loose or not plays a big role into decision making, and whether or not the condyles are involved in potentially compromising the ligamentous stability of the knee replacements. So my treatment algorithm and how I think about these is, first I consider whether the implants are loose or whether there's condylar involvement. If this is the case, then really revision arthroplasty, or most of the time a distal femoral replacement, is really the best option. If they are not, if their implants are not loose and the condyles are not involved, then you ask yourself, based on the femoral bone stock remaining, is the fracture fixable? Also considering the patient age and comorbidities, if you fix the fracture, are they going to be able to comply with weight-bearing restrictions, or is that going to make them more bed-bound? If the answer to that is no, then obviously revision arthroplasty or distal femoral replacement is the best option. If there is remaining bone stock and they're a younger patient that would potentially be able to be non-weight-bearing or partial weight-bearing for a period of time, then you can consider fixation of the fracture. Question next is the fracture axially stable, and is the components, does it have a cruciate retaining or an open box? And if that is yes, you can consider an intramedullary nail, and if no, most of the time plate fixation is the best option for that. So really, this is kind of the algorithm that I use to decide whether fixation or arthroplasty and how to fix these fractures. So we'll go over a little bit of each of these in detail. The indications, in my opinion, for a distal femoral fracture, distal femoral replacement, are very distal fractures with condylar involvement and ligamentous compromise, obviously with loose implants, and in patients with very elderly or elderly patients with very osteoporotic bone. So really, by doing a distal femoral replacement, really don't need any biology or healing at all in those patients with compromised healing potential. So here's a case out of a series here. So obviously here's a supracondylar fracture. Both of the condyles are involved. There's even a non-displaced fracture up into the distal metadiaphyseal region in a very elderly and 80-year-old female patient. So I think for me, this is best served with a distal femoral replacement. You can see the cable placed for prevention of propagation of the fracture, cemented stems on both sides. The main advantages of this are immediate weight bearing. Like I said, you surpass the biology. There's no need for any healing at all. Some disadvantages, obviously, is a little bit larger case, potentially higher blood loss and medical complications. And if you don't have a good technique and do it right, there can be extensor mechanism complications, which we'll talk about. Some technical tips I think that are important in these cases and doing them appropriately is one, I think avoiding distalization of the femoral component is very important in these to avoid extensor mechanism complications that we often see with rotating hinge devices or distal femoral replacements. Really distalizing too much puts a lot of strain on the extensor mechanism in the patella. What I do is I clamp the extensor mechanism and really look at the patellar height and flex the knee to make sure that the distal femoral component is not coming basically out and pushing on the arthrotomy too much throughout flexion. As you see here, these patients obviously are already shown that they're poor bone quality and fracturing. So I think really cement fixation is ideal for them. And then lastly, setting femoral component rotation can be a challenge in these. What I do is you can feel linea aspera to get you on the posterior aspect to get some sense of rotation of the component. But what I mostly do is float the femoral trial within the knee and take the knee through range of motion and really where the patella tracks perfectly. I mark that and we'll plan to cement in the component at that rotation. And then finally, obviously, expedited surgery in these medically frail and complex patients to avoid, high blood loss and potential post-operative medical complications. We published our series of distal femoral replacements for supracondylar fractures around primary and revision total knee replacements. We had 49 patients, 34 of which were after primary total knees. With cemented fixation in these patients, they had a 97% survival rate at 5 years. So, excellent fix in a primary knee is an excellent outcome for patients, with cemented fixation. However, there was a higher incidence of medical complications in this, basically hip fracture type population. However, in conversions of a failed ORIF or after a revision total knee, there was a 5 times higher rate of re-revision for loosening, infection, and refracture. So similar to Beth's point about on the hip side, these are very challenging cases. So to briefly go over a couple of other options for fixing fractures, the indications, in my opinion, for an intramedullary nail is an axially stable fracture with adequate distal bone stock and a CR knee or an open PS box. And there are some sizing charts that you can find in Excel chart to help guide size of the nail. So this is a case that I did as a resident. So it's an axially stable fracture with good distal bone stock. Components are well fixed, and we place an intramedullary nail with multiple fixations. So the advantages obviously is biologically friendly. You can allow patients to weight bear. The disadvantage is that you often get this hyperextension deformity as seen here because the box is more posterior than what a normal starting point would be. The question of whether you replace the poly and how to do the technique obviously is a little bit more challenging and unfamiliar, especially for a lot of arthroplastic surgeons. Locked plating, the main indications are adequate bone stock, acceptable biology, and the ability for potential for non-weight bearing or toe touch weight bearing for a period of time. This is a case of Dr. Gosden's, where a spiral periprosthetic fracture above a knee, in which she did dual plating and as she said in the principles for her hip, spanning the length of the femur and really getting fixation and respecting the biology. The techniques, the locked plating is a little more familiar to most surgeons than an intramedullary nail, but you really need to respect the biology, use AO principles among plates, and the question remains whether double plating or single plating is necessary, and can the patient sustain toe touch weight bearing for a period of time. So again, just briefly, my treatment algorithm and how I think about these: are the implants loose? Are the condyles involved? Is the patient too medically infirm to be able to deal with non-weight bearing or partial weight bearing for a period of time? And then if you're going to fix these, is the fracture stable, or is it a CR design in which it would be potential for intramedullary narrowing? So that's it. Thank you.